Good afternoon, good morning, good evening, depending on where you are throughout the globe. My name is Abdelal Housawi. I'm the Vice President of the Global Sepsis Alliance for International Affairs. It gives me a great pleasure to be chairing and moderating this session. Basically, the session is titled Combating Sepsis, Global and National Strategies. So I'm just going to share with you some background and some housekeeping rules. So the duration of the session is 90 minutes. We have both panelists as well as audience within the vicinity here and also virtually. So two of our panelists are joining us virtual, but three of the panelists are here, and I'm going to introduce all the panelists in a moment. So audience joining us virtually, you guys could start writing questions from now as the panelists start speaking. What we'll try to do is, depending on the time, that we might have some questions after each panelist, and then we'll also have some time for Q&A at the end as well. Audience here within basically this room, we have two mics on either sides of the room. So during the time of the Q&A, you could just walk up to the mic and then just wait for the opportunity to speak. We were instructed to remind you not to touch the mics, so you could, the mics are actually open and you could speak right away. So just from infection prevention control and COVID. Now, why are we here? I think by the time we finish, I hope that we could move the agenda of improving the situation for sepsis forward. Annually, almost 50 million people contract sepsis throughout the globe. It results in more than 11 million people losing their lives. If you compare that to COVID-19, last year COVID-19 claimed the lives of 2.5 million, and it actually attracted, and rightfully so, the global response, from east and west, north and south. The question is, what are we doing about this, what I call the overlooked pandemic? 11 million people dying on an annual basis. That's a big problem that requires all the concerted efforts. Back in 2017, with the great efforts of the Global Sepsis Alliance and led by Professor Conrad Reinhardt, the WHO and the World Health Assembly came up with a resolution that is a very, very good document towards actually solving this problem. I think, to be very frank, there's still a big room for improvement in the journey towards implementing that resolution. So I think what I would ask from the panelists, as well as you as an audience, while we're listening to the panelists, thinking we should ask ourselves the question is, okay, how can we save one more life? How can we save, million more lives? How can we save few millions of lives as we're moving forward? So without a further ado, I'm just going to go through the quick introduction of the five panelists that we have. So starting first with Professor Jean-Marc Cavillon is an honorary professor at the Institut Pasteur in Paris. He was head of the unit cytokines and inflammation from 2001 to 2017. And he's presently the scientific officer of the French National Research Agency, ANR. The second speaker is Dr. Jeanette Victoria Diaz. She's the team lead clinical management in the WHO. She is an intensivist by specialty with expertise in clinical medicine and global health. And she's committed to work with medical and public health professionals to deliver quality and safe and cost-efficient care to critically ill patients in resource-limited regions. The third speaker is Dr. Caroline Flichmann. She's a research associate at the Jena University Hospital and leads the research area health services research in infectious diseases and infectious control here in Germany. The fourth one is Professor Conrad Reinhardt, and he's the founding president of the Global Sepsis Alliance, and he's done a huge work and continues to do efforts towards the solving this global problem of sepsis. So he's going to be our fourth panelist, and the last but not least is Dr. Flavia Machado, who's also a vice president of the Global Sepsis Alliance for special projects. And she is one of the leaders of the sepsis work in Latin America. She was part of the basically the Latin America Sepsis Institute. So without a further ado, I'm going to ask the first speaker, Professor John Cavillon, to come over and speak.
Well, thank you, Abdullah, for this presentation and introduction. I'll be trying to address what Conrad asked me to address, which is the pandemics and sepsis and the role of immune response. And first, I would like to thank Conrad for his very kind invitation, and it's an honor to speak in this meeting. Thank you. So despite Conrad put an S to pandemics, I will not address all the pandemics that humanity has been suffering for many millennium, and I will just focus on I apologize, I have some clearly problem with mastering the remote control. Well, so I will focus on of course, on COVID-19. So, of course, in terms of the immune response, as you know, the first interaction will be the sensing of the virus. And it has been clearly showed that the host is equipped with sensors like the TLR3 and 7 that will send the RNA, and also the TLR2 that will send the envelope of the virus. After sensing, the immune response will be initiated. First, the innate immune response involving immune cells and immune mediators, finally ending to the adaptive immune response that end to the production of antibodies, the memory B cells and T cells. This adaptive immune response hopefully will end to the control of the infection and resolving of inflammation. Unfortunately, in this severe COVID-19, this is ending to deleterious effect, and it's what we can consider as a sepsis. So most of the other fully consider that the SARS-CoV-2 infection is a viral sepsis, and this is clearly discussed widely and admitted widely. However, regarding the interaction of that virus with the immune host response, it's clearly a struggle against a smart virus, because in fact the virus has many mechanisms of immune evasions, and among those, as you know, interferon is one of the key elements to fight against viral infection. But the virus has elaborated many players in its genome that will block the signaling of the after sensing and the effect of interferon. So this is a first challenge. And in fact, in terms of immunopathology, there are many aggravating factors such as the complement activation, the alveolar macrophage activation, the netosis, the alarmin release, the auto antibodies against interferon, type 1, and other processes such as coagulation and viral cytopathogenicity. For example, regarding the complement activation, it has been published that the C5a receptor axis was involved in the SARS-CoV-2 inflammation. And interestingly, research on COVID-19 has been an opportunity to rediscover what we have known over 20 years, and especially in terms of bacterial sepsis. And 20 years ago, it was known already that in bacterial sepsis, C5a is playing a major role. Among the other mechanisms, for example, it has been shown a synergy between TNF and gamma interferon. And regarding the cytokine, we know that they have both half-angel, half-devil aspect or beneficial and deleterious effect. But again, the synergy between TNF and gamma interferon was known for the last 25 years. And a paper was published when at that time people were studying the endotoxemia, which was trying to mimic a bacterial infection. Among the other parameters of immunopathology, as you know, there is the immunosenescence that includes the decrease in both the innate and adaptive immune response, in addition to the exacerbated production of inflammatory cytokine, also known as inflammagine. And among other comorbidity parameters, obesity has been shown to be one of them. And for example, this Mexican study showed that SARS-CoV-2 review showed that SARS-CoV-2 infection could potentiate the status of systemic inflammatory disease in obese people via the activation of the NLRP3 inflammasome and the release of pro-inflammatory cytokine, as shown on the right part of the slide, showing that macrophages in the fat tissue are producing inflammatory cytokine. And in fact, the inflammasome activation has been clearly established in COVID-19 patients, as shown here in these biopsies of lung of patients who died of COVID-19, clearly establishing the activation of the inflammasome. The other topic is, of course, has been the cytokine storm. And many papers at the very beginning of the pandemic consider and publish in the most famous journals that COVID-19 was a cytokine storm. And many papers have been published in the past about that. However, with my colleague of the European Shock Society and with my colleague of the European Group on Investigating Sepsis, we really ask ourselves the question, is it really a cytokine storm? And in fact, our colleague in the States also asked the same question, is a cytokine storm relevant to COVID-19? And the answer is clearly no, it is not. And I like to mention this paper that has been just published in Shock by the group of Dan Remick, comparing the levels of interleukin-6 in SARS-CoV-2 severe patients as compared to other clinical settings. And you really can see that we are not dealing with a cytokine storm. So in fact, we are dealing with a cytokine drizzle. However, this reminds me what I proposed 20 years ago about the compartmentalization of the inflammation. And in fact, it's not a cytokine storm in periphery in the bloodstream, but it's a cytokine storm within the lungs. So compartmentalization is important, and COVID-19 is just an illustration of what I mentioned 20 years ago. And this is just one paper among many others establishing that in COVID-19 patients, yes, indeed, as compared to other clinical settings, there is a cytokine storm within the lungs. Now, as for bacterial sepsis, this phenomenon is associated with an altered immune response. And this has been very nicely showed by the group of Richard Hotchkiss, showing that there was a severe immunosuppression and not a cytokine storm. And they investigated ex vivo the interferon gamma production after stimulation of the cells. And as you can see here, comparison of the ELISpot between healthy controls, critical ill, non-septic, septic, and COVID-19. Clearly, as shown on the graph, there is clearly an hyporeactivity of the T cells to produce interferon gamma, and they showed that IL-7 could restore the gamma interferon production. And at the same time, in the same study, they also investigated the ex vivo TNF production following stimulation with LPS, and once again, they showed that in COVID-19 patients, there was a severe reduction of the capacity of the cells to produce this TNF. However, the group of Peter Pickers in the Netherlands considered that COVID-19 patients exhibit less pronounced immune suppression compared to bacterial septic shock patients. Another way to monitor the altered immune response is to measure HLA-DR expression on monocytes. And as you can see here, the expression of HLA-DR, which is very much decreased in bacterial sepsis, is poorly decreased in COVID-19 patients. Now, to end with this topic, I would like to mention that therapies have been proposed targeting immunity players. And for example, there was this review saying that we should use the lessons learned from sepsis. But this reminds me, let me have a smile, because this reminds me of a paper I just published last year saying that, in fact, sepsis therapy has been 30 years of translational research failure. However, different approaches have been of interest. And for example, there is this meta-analysis of the interleukin-6 as a target. I'm not sure it really makes sense to target IL-6, but that's another story. But interestingly, in this study, you see that the placebo-controlled study did not end to any significant improvement by the treatment, whereas the open-label study showed an improvement. So I think this is also very important to take into consideration the quality of the research and the protocol that has been followed. The other idea is also to target interleukin-1 with the IL-1 receptor antagonist anakinra. And this is another meta-analysis just published showing that altogether anakinra seems to have some efficiency to reduce the mortality in moderate to severe COVID-19 sepsis patients. Another interesting approach has been, I did not have time to address that aspect, but netosis, which is the release of intracellular content of neutrophils within the lungs, has been shown to be associated with COVID-19. And there is this study showing that intranasal administration of recombinant human DNAs may have significant therapeutic implication. And finally, I would like to mention the work, but probably Jeannette will address that more than I can do and have time to address, of course, all the possible beneficial effect of corticosteroid. With that, I will close and thank you for your attention.
Thank you very much, Jean-Marc. We have time for one question, either from here. We can also, leave you to think about those this presentation, and we still have time at the end. Thank you very much, Joe. So next is Dr. Jeanette Diaz, and she also will be addressing us. And again, think about having any questions either after the talk or towards the end. Thank you.
Thank you. I want to give a great thanks for the opportunity to speak here. Thanks to Conrad and the organizers. I lead the clinical response to COVID-19 at the WHO Health Emergencies Program, and I'm just going to give you a few perspectives and lessons learned from that experience and how that can relate to sepsis. Quickly, just as from our website this morning, you can see that there's nearly 5 million deaths due to COVID-19. In total, and in the past 24 hours on the top left, about 7,000 deaths reported to the WHO. So if you look at these and you consider that COVID-19 or SARS-CoV-2, one of the major results of death in those patients due to sepsis, then the estimates that were described by my colleague there of 11 million deaths a year increase quite substantially. WHO included sepsis in the COVID-19 severity classification since the beginning of the pandemic, even in our first guideline that was published in 2020. And you can see how we use the definitions. On the bottom left is our infographic showing the populations how we're writing our clinical guidelines. And you can see there in the critical component that patients with sepsis, septic shock are labeled as critical COVID-19 because of their high risk of death. And then in the right side, you can see the definitions for sepsis, very similar to the definitions that have been publicly available for years of sepsis and septic shock in adults and children. The readiness and response strategies for COVID-19 clinical management, I think there's a lot of lessons here that we can learn and use and replicate for making national strategies for sepsis. At the beginning, we start with prevention. vaccines, infection prevention and control for COVID-19, and ventilation, and public health interventions. Then we move on to early recognition. We need to make a clinical diagnosis early. We need to know who's at risk, and we need rapid diagnostics to confirm that diagnosis or confirm the pathogen that is, or in this case, COVID-19. Triage and clinical assessment, acuity-based triage to identify those that are most sick, early emergency and critical care services, and a WHO severity classification, so you can start to classify your patients and put them into the right treatment pathway, and prognostic models, which still we don't have for COVID-19. Care pathways by disease severity. So what we've chosen is to help classify patients. So you identify them, you classify them mild, moderate, you go into a disease, into a care pathway. If you're severe critical, you go into another care pathway. Of course, you can go between the different care pathways, monitoring and prevention of any complication throughout your care. And finally, recovery and beyond. For COVID, obviously, we're dealing with long COVID. We call it post-COVID-19 condition, and that the care systems are in place for those patients. In order to do this, we need to make sure that our systems have the staff, the supplies, the structures, the systems, and the security in order to deliver this care. So perhaps we can apply the same strategy for sepsis to strategy for COVID-19 to sepsis from other pathogens, and avoid the vertical programs where we separate each disease or each infection into separate pathways. This needs to be integrated into the health system. And remember to keep the patient and the community at the center. I want to highlight some of our normative work where you can see how we approach the clinical comprehensive care of patients with COVID-19, including those who have sepsis. And you can find these on our website. Our clinical management guideline is the orange one, the SARI toolkit, which actually has many tools related to sepsis. On the bottom left, the basic emergency care training course. And I want to highlight two special things as well in here. There's a priority medical devices. And so we have done a great amount of work at WHO in order to ensure that the right medical devices, biomedical equipment, and PPE and diagnostics, but I'm going to focus on biomedical equipment, that those technical specifications are available to member states so they can buy the right equipment to use with patients. And then also a roadmap to improve ventilation, and training materials that can be found on openwho.org, both on comprehensive clinical care from the outpatient to the inpatient setting, as well as on critical care. Therapeutics in COVID-19. I want to highlight that there's been major advancements in the landscape for therapeutics for COVID-19. Again, lessons learned here. And I'm not going to go into the wonderful explanations that my previous colleague described us through the mechanisms of potential ways that therapeutics can be targeted to treat COVID-19, but we need to learn here. Antivirals being tested, some recent press releases of certain ones, but we hope to receive full results of studies that are ongoing testing at new antivirals. Monoclonal antibodies, those have been tested also in the throughout the COVID-19 pandemic, and we are seeing some promising results to some of them. Immunomodulators, and of course what we just heard is there are many potentials for immunomodulation, again at a certain patients. Large platform trials have accelerated testing. Drug development has continued. So I think that, the great investment for so many colleagues around the world in academics, in drug developing settings, in order to speed up access, to speed up the science around therapeutics. Later, I will talk about access. And then our WHO Living Guideline on Therapeutics has been able to take some of this data, synthesize it as it's coming, and try to provide trustworthy and transparent guidelines. So I do think now with these lessons learned, we can conduct robust clinical trials across the world for other causes of sepsis to inform clinical practice guidelines. And just a note on the right is our process for developing our therapeutic guidelines. We have a timeline of about 2 months from data available to actually publication of a guideline, which is quite rapid, but it's called the Living Guideline. And those are 2 meta-analyses that WHO coordinated on IL-6 and corticosteroids, and then a living network meta-analysis that informs our guidelines for the remaining of the drugs. A note on our therapeutic guidelines, I can just tell you we have 3 publication platforms. One is our WHO website. One is an electronic data platform called Magic App. If you go to there, it's actually interactive and you can quickly hover and look on evidence to decision tables, summary of findings tables to look at the statistics that are informing the trial, the recommendation. And then on the right, you will see an infographic, and that's published in the BMJ with each of our living guideline update. We're on the 6th update of our guideline, and there you can see the recommendations by drug and what patient population. And the most recent recommendations we made was for the combination, a conditional recommendation for the combination of casirivimab and imdevimab for patients with COVID-19, and those that were mild and moderate, those that patients with the highest risk for hospitalization, and in those with severe critical, those that were seronegative. I do encourage you to go to these publications and explore how you can look at the evidence to understand the recommendation. In the final moments, I want to talk about optimized supportive care. And here I want to talk about it, no one size fits all solution. The point of that comment is to say, it may not be one drug that's going to solve everything. We know that. We must invest in the basics and the basics of clinical management. And what we've learned from this pandemic, I'm sure that you guys, those of you that are working in resource limited settings, or you've seen it in the news, the access and safe use of medical oxygen has been brought to the forefront. So we started an oxygen access scale-up initiative. And if you read that commentary there, you really clearly see that the medical oxygen is life-saving and an essential medicine. It can be used at all levels of the health system and is crucial for the treatment of COVID-19 and other life-threatening conditions such as severe pneumonia, severe malaria, sepsis from bacterial or viral infection. So I think here, just again, signposting that we are talking about sepsis, and we talk about sepsis, and we talk about oxygen. Oxygen is life-saving for the communicable diseases and obviously also for the non-communicable diseases to ensure safe surgery, to ensure safe maternal care, et cetera. So WHO is taking a collective action to improve access and safe use of medical oxygen. We worked with partners to have a UN global supply chain system that was targeted to provide biomedical equipment quality assured to member states since the beginning of the pandemic. Most recently this year, we've been working on an emergency oxygen task force to focus on larger scale oxygen initiatives to generate larger scale oxygen. And this has been a tremendous collaboration between multiple partners and UN agencies and member states. And there has been major investments by donors in this past year in this space. So where are we at with our clinical care pathways? I simplified it here because I want to make everything back to where back to the basics. Mild, moderate COVID-19. So these patients may be treated in the outpatient setting, if that's the system if that's the care pathway in your setting. Home care monitoring, so the use of pulse oximetry can be a simple device to kind of help with early detection. However, if you are deteriorating, that patient must have access to some care, so integrated into a referral system and a referral pathway. We do have now that new conditional recommendation for this monoclonal antibody, casirivimab, imdevimab, that antibody cocktail. And the reason is for reduction in the risk of hospitalization that was seen in those highest risk patients. For severe and critical disease, you can see here, those patients will need oxygen therapy. If they develop more critical disease, advanced respiratory support, such as CPAP, non-invasive, high flow, invasive, and then the prone positioning. So the simple mechanism of putting someone on their abdomen to improve oxygenation. And the treatment options here that have been shown to reduce mortality and need for invasive ventilation. And again, I send you to the guidelines to read the evidence behind those recommendations. Corticosteroids with an small added benefit with IL-6 receptor blockers if they're added on to corticosteroids. And then most recently, the casirivimab, imdevimab in seronegative patients, as those patients were found to have a high risk of death in that study. So I think this slide got moved out of out of order, but I will just focus here. This is back to the oxygen. The oxygen work is a complex piece of work, and I don't know if any of you in the audience are biomedical engineers. There's two aspects here that we have to deal with, is the technical aspect on how to put in oxygen generation devices at a larger scale, be it PSA plants, which are large concentrators, or liquid oxygen sources that need to then be vaporized into oxygen and then piped or distributed through cylinders. And so this is a very complex system that needs to be scaled up at scale. In addition, then you have the patients at the bottom where you actually have to use the oxygen safely with the appropriate medical devices to take care of that patient. So there's a lot of work being done at the biomed side, technical side, and at the clinical side to improve the delivery of oxygen. Finally, this is my last slide. So opportunities for readiness and response to sepsis. Perhaps we use established care pathways for COVID-19 as a model to expand to other causes of sepsis. Early detection, rapid diagnosis for relevant pathogens, access to primary healthcare, including early emergency and critical care, optimized supportive care, and disease-specific therapeutics. Ensure access to life-saving therapies are available to all patients with sepsis. Includes equity in access to vaccines, and we know that's been a huge problem with COVID-19, and so we want to be transparent about that. PPE, access to therapeutics, and oxygen. Build and strengthen workforce in biomedical engineering and clinical workforce. I think this is a big need to care for the severely ill patient, and integrate investments into the health system to ensure funding and resource sustainability. Thank you.
Okay, we have one question.
Thanks, Jeanette, for this great talk. And you mentioned rightly that WHO from the beginning, and especially your unit and team, has clearly spoken out on the relationship between COVID and sepsis. And I just wonder, because this knowledge did not spread out, because I'm pretty sure if you would do a poll, less than 1% of policymakers and lay people have understood this. So what do you think? What's the reason for this?
Oh, I don't know. I think it's, the responding to COVID-19 has been a tremendous challenge for all of us everywhere within WHO, at the national government level, and then at the, the health workers, those that are actually doing the care and in the community. So although these messages have been there, have been out, and I'm hoping the clinicians have used our guidelines or used other relevant national, professional guidelines that have similar approach and recommendations. But I cannot explain why. I do think that we have included this and tried to message this, but I would like to take this opportunity at this meeting to clearly say on behalf of WHO that we do acknowledge that viral sepsis from COVID-19 exists, that we do acknowledge that now these care pathways, and we want the investments that have been put into the system for COVID-19 to be sustained, to work into the resilience of the health system. And that should be learned to use to care for those very sick with, those with sepsis, with an infectious disease, as well as the integration into, other non-communicable disease care to improve the health system in general, because we want equity for healthcare. Everyone deserves to live a meaningful life and have access to, safe health care. So I think that brings us back to the universal health coverage, point as well. So we have to continue to move forward together. That's what I could say, Conrad.
Thank you. Thank you very much, Jeanette. And if I could just speak to the point that Conrad mentioned, I think we have this still disconnect between the technical and scientific society and the policymaker society, and we've had a very good experience in the patient safety, global movement with many efforts that was actually led by the UK and Germany, which is a global ministerial summit on patient safety that started in 2016, and we had 4 summits. The last one was in 2019 in Jeddah, Saudi Arabia. So that platform of having ministers of health and policymakers under one roof with the technical people, I think helps. So I think we need to have that, to do more of that, not just with patient safety, with many aspects. So moving on with a seamless transition from this vicinity towards the virtual panelists, we have Dr. Caroline Flichmann. So the floor is yours. I hope that you can hear me and see me.
Yeah, thank you very much.
Perfect. Go ahead.
Yeah, I'll share my screen with you and I hope that works.
Yep, we see it.
Great. Okay. So let me start my presentation. Yeah, thank you for the introduction and the invitation to talk at the World Health Summit. I would like to address the current evidence on the burden of sepsis and the challenges we face in investigating the burden of sepsis. It was already underlined that sepsis is a major public health challenge. So we see many patients in the hospital and the ICUs. The acute mortality is still high, and those who survive sepsis, they suffer often from long-lasting and life-changing long-term consequences. However, for most countries, the population burden of sepsis remains unknown, which hampers policy and research efforts. The possibility for monitoring and benchmarking and the identification of high-risk populations. The WHO therefore urged its member states to improve their sepsis epidemiology research and just recently issued a report on the global epidemiology of sepsis, which is a good read for all interested in that topic beyond that snapshot of my talk. So what do we currently know about the burden of sepsis? The most comprehensive study on sepsis epidemiology suggests that around 50 million patients worldwide are affected by sepsis every year, half of which are children. Just for comparison, the burden of disease study estimated around 12 million incident cases of stroke annually. Sepsis can be considered a major contributor to health loss. Around 11 million patients are estimated to die with or from sepsis every year. Many have underlying non-communicable diseases or injuries that lead to hospitalization or compromise immune function. And over time, you can see this on the right side, the mortality of sepsis was found to decrease by approximately 30% in a 30-year time frame under observation in that study, mostly by the great reduction of the burden of infectious diseases in low and middle income countries. But sepsis is not only burdensome in terms of acute mortality. Survivors often suffer from long-lasting physical, mental, and cognitive impairments, which persist even months or years after the acute disease. In a recent study among German sepsis survivors, the so-called SEPFOC study, we found that 3 out of 4 sepsis survivors suffer from new impairments in the year post-sepsis. And around 1/3 of patients not dependent on prior nursing care were dependent on formal or informal care in the first year after their acute disease. And about 1/3 of patients died in the year after their sepsis hospitalization. Most common new impairments were neuromuscular or cardiovascular diseases, and interestingly, nursing care dependency and an increased long-term mortality were not only found in patients with severe or ICU-treated sepsis, but also affected sepsis without organ dysfunction, formerly known as non-severe sepsis, and non-ICU-treated patients, and also patients without prior impairments, which means that the population of survivors that requires specific aftercare after sepsis is really large and not restricted to patients with the most severe manifestations, which is similar to what we experience also among COVID-19 survivors. When we talk about the burden of sepsis, it is also important to consider that low and middle income countries still bear the highest burden of sepsis. and sepsis-associated death. And also mortality is up to 10 times higher in these countries compared to high-income countries. We still really lack reliable data to monitor and understand the burden of sepsis in these countries. The Global Burden of Disease study, for example, used data from the Global Burden of Sepsis study used data from selected countries to extrapolate the incidence and mortality from 10 or 4 countries to all other countries, considering access and quality of healthcare. And this lack of study is really a major challenge in the assessment of the global burden of sepsis. And above that, the results from existing studies, mainly from high-income countries, can often be barely compared and suffer from limited validity. And these problems, for example, arise from heterogeneous study designs and data sources, different sepsis definitions, and a lack of standardization in complete reporting of outcomes. And if specifically administrative data are used to generate sepsis epidemiology estimates, the incidence of sepsis is often underestimated, as the diagnosis and coding of sepsis is incomplete. As example, the incidence of sepsis among US patients was 2.8 based on coding and administrative data, and 6.0% based on clinical criteria and electronic health records. And this leads to very different estimates comparing the clinical data and administrative coding, for example, used in the Global Burden of Sepsis study. And for Sweden and the US, estimates based on clinical criteria generated incidences twice as high as estimated in the Global Burden of Sepsis study. That means we face a considerable underestimation even in this comprehensive study. So how can we do better? We need additional advocacy and funding to generate better evidence on sepsis epidemiology, for example, by national action plans or international research collaboratives. And it is also important to really improve the data sources for sepsis epidemiology research and to achieve a consensus on a definition of sepsis that can be used across all settings and in all regions of our world. And the quality of ICD coding and the quality of administrator needs to be improved to generate better estimates on sepsis epidemiology. And we need standards for reporting and conduction of epidemiological studies and core outcomes to make estimates more comparable. This all is crucial to understand and finally reduce the burden of sepsis and also to reduce preventable deaths all over the world. Thank you very much.
One question also to you, Caroline, because you have done this great Severity study with one of the biggest healthcare insurers in Germany. And I know that there are debates in the German Ministry of Health, but also on the level of WHO to define what is called long COVID. Why do you think that although there are publications on the long-term sequelae about sepsis since 20 years, why is it that nobody until now has taken up this issue on the political level in any country?
Well, I think that has several reasons, and one is the lack of lobby sepsis survivors have. We see that long COVID or the post-COVID syndrome receives a lot of attention from political side and also media, and that is something which is lacking for sepsis. Sepsis is not known among the general population, and similarly long or post-sepsis syndrome is something that isn't at the political agenda, and also the need that survivors and their caregivers often have, that's nothing really present for policymakers and also the healthcare system at the moment. And I think it's important to generate more data that underlines the burden of long-term sequelae and the need that these patients and their caregivers have to improve also the clinical care.
One more question. Go ahead. You need to speak from the mic there.
Okay. Thanks a lot for your insightful presentation. I was wondering, in the study you conducted, if antimicrobial resistance has any substantial effect on sepsis outcomes. Did you look at that angle?
Yeah. Yeah, we found that the infection with antimicrobial resistant pathogens affected some long-term outcomes, for example, long-term mortality, but not all adverse outcomes after sepsis. I think it's we used administrative data as well to assess the long-term outcomes of sepsis survivors. And in this data, it's often not really easy to identify the underlying infection. So all we can see is, or we can say, is cautious, but we find signs that MRI infections have an impact, a negative impact on long-term outcomes.
So one last question. Go ahead, if you can introduce yourself. And
my name is Brigitte Bürlen. I'm the founder of the WUI Foundation of Caregivers. So my question is, if there is a lack of interest, or there's less knowledge of sepsis in the normal population, where should there be the interfaces for? I think there's I excuse myself, but there's an ivory tower, and if people sit in this tower, so normal persons, they don't know anything about it. So shouldn't there be more interfaces? And perhaps we should think about building some bridges for the caregiver, the relatives of persons who suffer from sepsis are also targeted in a highly of this topic.
so let me paraphrase that question. We're in echo chamber here, and how can we break out to the average person to explain sepsis?
Yeah, well, I think that's a very important point, and something on top of that needs to be placed on top of the agenda. I think it is important to have valid figures to underline the need. That was something we tried to produce regarding the post-sepsis sequelae. And then, of course, it needs to, we need campaigns and public health interventions to really increase health literacy of sepsis survivors and also their caregivers to empower patients and their relatives, and to also to improve their care. So I think that's a major issue that needs to be done in the future. Yeah.
Thank you very much, Caroline. So again, let me remind you about the numbers. Almost 50 million a year get sepsis, and more than 11 million people die That's a huge problem. So on one end, we've got this problem. We've got a very good document, that resolution that came out in 2017. But one challenge that continues to exist in healthcare is the siloed approach to things. You know, I attended this brilliant session this morning about critical shortages of nurses throughout the globe. And believe me, whatever we do here and whatever we talk about, you know, how do you prevent sepsis? Either by preventing infection, big portion of what nurses do, or by early recognition. Again, you know, if you've got the early recognition is also nursing. So if you have a nurse that has 10 patients that he or she is looking after, we're not going to solve sepsis. So we can talk about, you know, you know, all the research, and we can talk about all the interventions. We have an issue within the healthcare system of lack of resilience, and I think somehow we, as the healthcare systems, not just the low-income countries, but also high-income countries, thinking about resilience. You know, I would say that the nursing issue and the sepsis are two sides of the same coin, of the lack of resilience, because sepsis is an outcome because of the lack of resilience of the system. One of the major issues of the lack of resilience is the issue of nursing. And somehow, you know, the same healthcare systems talking about improving resilience, they're actually kind of tone deaf to, you know, the issues like the nursing situation, issues like patient safety, et cetera. So we really have to kind of reset the discussions and really try to think in a collective way, and dealing with the healthcare system as a complex adaptive system. Otherwise, we will just continue to have more problems. So it gives me a great pleasure to introduce Professor Conrad Reinhardt, who's going to do two things. He's going to actually speak, and then he's going to take over my chairmanship, because I have to run to the airport. So I hope that the rest of half an hour will be as exciting as the first 50 minutes. So thank you very much. Conrad?
Yeah, thank you. And it's indeed a pleasure. How can I move forward? Can you? Okay. So now I need to go back. Okay. Okay, so most people don't know what sepsis is, and that's why I tell it again. It's a life-threatening condition that arises by the host response of the body to an infection. And everybody knows what cancer is. Anybody knows what HIV is. And there were times where the awareness for infectious diseases and sepsis was high. This quote by Sir William Osler, the most famous physician of his times, said, "By far the greatest and most terrible threat to mankind is fever, which is a synonym of sepsis." And even still in World War II, and this is a poster by the British Army, and they warned their soldiers to look for sepsis, the early signs of sepsis, because it has at its discredit more victims as the joint German forces together. And to not know the symptoms of sepsis is to neglect yourself and to help Hitler. So why was it that this notion disappeared? And this notion, on the other hand, is still true. What you can depict from this number here, and I don't explain it again because we had heard it several times. And already William Osler understood that except from a few occasions, most patients don't die by the pathogen itself, but the body's response to these pathogens. And this simply everybody should know, every physician should know, because this implies that we cannot need to treat sepsis different than uncomplicated infections. It's not just about the antimicrobials and the antivirals, we heard it, it's supportive care. its support of organ dysfunction. And why is it that we have forgotten about the burden of sepsis? It's ironically the dramatic improvement and reductions of the crude mortality rate, and this is from America. This was not the case in, of course, the same in other high-income countries, but not in Africa and elsewhere. And you see, this was by measures that sanitation, hygiene, chlorinization of water. It was by invention of penicillin, vaccination, etc. And you see that this was only interrupted by the Spanish flu in 2019. And we are again at a Spanish flu. We knew it would come. We talked about this 10 years ago, and I don't want to go into it. But this success in high-income countries had a bad consequence, because there were people like a Surgeon General and several Surgeon Generals who said at this time, the book of infectious diseases can now be closed. And this was detrimental, because I didn't learn anything in the medical school about sepsis in the 60s, late 60s and 70s. There were no guidelines on the treatment on sepsis. When I learned in the ICU here in Berlin that it's the #1 killer in the ICU. And despite the fact that very known people, and the last one was Bill Clinton, who just came out of the hospital from a urosepsis, and if you have seen the CNN report, he is hidden by this by these facts. And as I said, 40 years ago, there was nothing, no data, no guidelines, nothing. Even 10 years ago, there was nothing on the website of WHO except for maternal sepsis. There was nothing on the website of the CDC, nothing in the Global Burden of Disease report. #1 killer in the Global Burden of Disease reports 10 years ago, or even 5 years ago, or 3 years ago, was lower respiratory tract infections. The word sepsis, they died from sepsis, but the word sepsis was not used there. And we needed to learn from other fields, because the cancer people understood in the 40s and 50s that you need to transform a disease politically before you can conquer it and transform it scientifically. And you can read this in this Pulitzer Prize notion. And they asked for a moonshot against cancer. They asked for a Manhattan Project. They had ads in the Washington Post, Mr. Nixon, you can cure cancer. And they changed the healthcare system in terms that the National Institute of Health, I said, prioritize cancer at these times, and it was rightly so. But on the other hand, and that's why understanding this with support of the German government, and also with the support of Margaret Chan, and with support of Jeannette, because jointly with her, we drafted the first resolution. And all of a sudden, when the decision was made, this was the ground for this resolution. And Sir Liam Donaldson has said, is a patient envoy of the WHO, the public and the political space is a space where sepsis needs to be in order for things to change. And we learned how important it was and is during COVID-19, that really you must and cannot leave the healthcare system to the physicians alone. You need to take care on the highest level. And this resolution was so important because we estimated 6 million. We know now that's 11 million. Most of them are preventable. It says it's the response from most infections, and it is a final common pathway from most infectious diseases. And this is 2017. It says also that is an emergency. Every hour of delay impacts outcome and consequences. it also says that it presents mostly as a clinical deterioration of common infections, but not only of common infections like urinary tract and gastrointestinal, but also from viral infections like Ebola, etc. And also COVID was mentioned in this accompanying report, and that it can be prevented. So, and that most of the cases can be prevented has been done and is out in the literature. This is a decline of sepsis mortality in Australia without any sepsis-specific campaign. Why is it? Because they have a very strong healthcare system. They have introduced 15 years ago what is called critical incidence reporting, which is called rapid response team. Can you move the slide? There must be but in other countries, and especially I'm so sad that this is the case for Germany, that the decline in a similar time period was much less. It was only 12% over the last years, whereas in other countries, it was much, much higher. And there are reasons for this, because we don't have, for example, mandatory critical incidence reporting. We don't have, can you please move forward? Oh, now I need to go back, sorry. And they have introduced this kind of rapid response systems 15 years ago. And this resulted in a decrease in New South Wales. And this was the case for whole, this introduction for whole Australia. They reduced the cardiac arrests by almost 50%. They decreased the death rate after cardiac arrest by over 50%. They decreased overall hospital mortality by almost 20%. And they decreased the resuscitation failure rate by a third. And not, of course, all of these cases were sepsis cases, but quite similar, a part of it. In Germany and many other countries, we still have reanimation teams. The physicians are called at cardiac arrest. And in Germany, 30,000 cardiac arrests take place any year in the hospitals. And one third is not recognized by, and happens without nurses. And this is a report by the Clinical Excellence Commission in New South Wales, which is based on the reports on critical incidence reporting, which there is centrally analyzed. And based on the fact that they realized that there's still room for improvement, can you please move forward? There is a room for improvement. They did a sepsis kills campaign. And after they found that in the emergency department, they were able to reduce mortality from 19% absolute to 14%, they rolled it out to the overall hospital. Next slide, please. And there on this slide, you see on the next slide, you see that their mortality rates decreased dramatically in the following time. Please, my next slide, sorry. And the impact of families, that things happened in UK, in US, and in other countries in the meanwhile, like Sweden, in France, etc., was great. They were no longer willing to accept poor sepsis care. And there the policymakers acted, and this resulted, next slide, please, in dramatic, next slide, please. For example, Governor Cuomo, can you go one back, had a regulation in 2013. And you see that mortality rate in the state of New York decreased by 1/3 from 32% to 22%. Governor Cuomo also had a Rory Stone's law because this child had died, that in the schools in the state of New York, children have to learn about sepsis. Next slide. The same happened in UK, so that the number of patients which have been recognized in the first hour after admission to the hospital that they would have sepsis and treated with antimicrobials and fluids, etc., increased from 30% to 90%, and this went along with a dramatic decrease in mortality rate. Next slides. And the same happened in Ireland. So this means it's doable just by educating in the healthcare system and the healthcare workers. Next slide, please. And that's why we are doing a campaign now in Germany to overcome some limitations on this. Next slide, please. And with this, I am at the end. And I bring this slide because Rudolf Virchow had a holistic One Health approach to medicine. And he said, medicine is a social science and politics is nothing else but medicine on large. And it is this year his 200th birthday. And lastly, he said, next slide, that medicine has the obligation to point out problems. The politician and the practical anthropologist must find the means for the actual solution. And there we are. This is the take-home message also for me and for this conference. It's all about, and we had the same discussion this morning when we talked on digitalization, et cetera, et cetera. So next and last slide, I would like to thank you and to join this vision. No harm, no preventable harm, and no preventable death. And that's what it's all about and why we are here. Thank you for your kind attention. I can also do it from here. And it's my great pleasure to introduce Flavia Machado, and she was already introduced, and nobody else has done more on the fight against sepsis in Latin America than she has, and they have done a huge job over there. And if we had this situation in all low and middle income countries around the globe, we had millions less deaths and sequelae from sepsis. Flavia, please.
Hello. Hello, thank you so much. Can you hear me, Conrad? Yeah?
And
okay. Thank you so much for giving me the opportunity to speak about challenges to fight sepsis in resource-poor settings. Of course, in 50 minutes, I cannot speak about all the challenges we have, but I try to focus on these 5 major problems. First of all, understanding the burden. I think that Caroline has already addressed this, showing clearly that the major burden is coming from low and middle income countries. But I will try to focus on another specific point, which is trying to understand what is preventable. There is a lot of discussion about if patients, mostly in high-income countries, are dying with sepsis or from sepsis. So we tried to understand in our settings in Brazil if this is happening, because there's a lot of noise. No, people are dying because they are aged, because they have a lot of comorbidities. They are not dying from sepsis, they are just dying with sepsis. And this is a major problem because we need to show the burden. We need to show the policymaker, the politicians, the healthcare workers, and the lay people that sepsis is really a burden and people are dying from sepsis, and this is preventable. So we did impact markup. We did a case control study. We included almost 3,000 people in almost 40 institutions. And we asked them to look at the last 50 deaths in their hospitals, paired by date of discharge with the last 50 survivors, and see in their charts if they had sepsis. And of course, we had 50% of sepsis, among the non-survivors. This was expected, but we did really want to know if the deaths was attributable to sepsis. So we did a very complicated analysis. I did not have time to go through this, but depending on the definition of sepsis we use, at least 25% of the deaths were attributable for sepsis, which means people in Brazil are not dying with sepsis in the hospitals. They are dying from sepsis. And I would bet that this is the reality in middle-income countries, in low-income countries. Maybe not such in a high percentage in high-income countries, but the burden is huge, and we need to recognize it to change it. The second aspect that I want to address is prevention. And of course, in 15 minutes, I cannot address everything about prevention. So I'm not to discuss everything about prevention of community sepsis, but I want to have a glance on the prevention of nosocomial sepsis. And there is this very nice publication coming from the group of WHO. And they say that there is a lot of burden coming from sepsis acquired inside the hospital. And we all know that the burden of nosocomial healthcare-associated infections is much higher in low and middle income countries, as it is multi-drug resistance. And now, during the last year and a half, we have another challenge, which was having this with pandemic, with the disparities, but much more enhanced because of COVID. So what happened on the last 1 year and a half all over the world because of COVID? I would say that in each hospital, we have this. This is a recent report coming from Italy, and they show that 46% of the COVID patients in the ICU had healthcare-associated infections, and 35% of them have multi-drug resistant infections. And the mortality rate for this cohort of patients in Italy was 30%. Unfortunately, at this time, I don't know that we have no clear data coming from low and middle income countries, but we do have data on mortality of COVID patients in our ICUs. For instance, coming from Brazil, this very nice data, the first 20, 50, 100,000 hospital admissions, and many of them were in the ICU. And these are the mortality rates for Brazilian ICUs. As you can see, the mortality rate is it's pretty higher than the mortality rate from high-income countries as expected. And in average, Brazilian patients from COVID that had mechanical ventilation had a mortality rate of 80%. So we do not have data on the percentage of those patients that had nosocomial infection or had multi-drug resistance. But I would bet that this was a major cause of death. These patients died from bacterial sepsis, from multi-drug resistance, from refractory septic shock, and not necessarily from viral sepsis coming from COVID. The third point is the issues regarding perception and quality of care. So we do have a lot of problems regarding infrastructure, resource, guidance, training, quality of care, and the safety, discharge, and survivorship. One major point is the absence of access to ICU. We have a lot of discussion about what is an ICU in a low resource setting, what defines an ICU, what is the cost of having an ICU, what is the necessity of this, as you do have a lot of basic problems to solve as well. But certainly the absence of ICU, it's a major problem, as you can see by these numbers coming from Sub-Saharan Africa and Southeast Asia. But it's not only on low resource settings, on low income countries. We do have problems even in Brazil, which is a upper middle income country. I know that this figure is very complicated, but anyway, it comes from our point prevalence in emergency department study in Brazil. I want you to look only to the upper side of the figure, which comes from our public hospitals. These are the private hospitals. This is the answer for the question, what was the immediate location from a septic patient that presented in an emergency department in this study? So in blue, the patients that were transferred to an ICU. It took them 1 day or 2 or 3 days, but finally they were transferred to the ICU. In green, the patients that were finally transferred to one ward. In pink, the patients that were transferred to another hospital. But 40% of these patients in emergency department, public emergency departments in Brazil, were in the emergency department for the whole hospital stay, and they were discharged alive, or the status was discharged death in 60% of the cases. And in Brazil, we do not have discharge against medical device. There is universal access to care. So the patients were treated and discharged from the emergency department. They stay there because we do not have access either to wards or to ICU for everyone. There's a problem with resources, and this is a very nice recent report from this group, which is trying to settle what are the minimal requirements for critically ill patients in low and middle income countries. We do have challenges about the bug, because of course, in some countries like Brazil, for instance, we have problems with malaria in Amazon forest, we have problems with dengue, but this is much worse in places like Africa and like Southeast Asia, and having different bugs leads to different sorts of guidelines and different treatment approach, which is also a challenge. Talking about guidelines and trainings, we are lacking specific guidelines for low and middle countries. Of course, the last recent published version of the Surviving Sepsis campaign had the contribution of a lot of experts coming from resource poor settings. We have new courses that are addressing these specific settings, but it is still a problem because if we do not have guidelines and a specific training for these settings, we cannot improve care. And improve care and have implementation strategies, it's of utmost importance. As Conrad has already mentioned, there is a lot of initiatives for implementation process. Even in low and middle income countries, we have publications on this, but we have nothing like the initiative of United States, of Sector 1. As you all know, it's mandatory in US that all hospitals report their compliance with the sepsis bundles. And this is the last publication that we have. It's more than 300,000 patients, and they show that being compliant with the bundles is associated with an improvement in mortality. But even for US, there is a lot of discussion. Why, for instance, in New York, it is much more, the compliance and the program runs much better than in the United States. So if it's a problem in US, we can imagine how is the challenge in settings like ours. But we have good news. This is the photo from the date where the mayor of São Paulo City, which is the major city in Latin America, signed the law turning mandatory that all public hospitals in our city now has to have sepsis protocols. So let's see if it is the first step in Brazil of something like what we have in US. And why all this is important? Because every time we see that how we treat patients, the quality of care, the socioeconomic status is related to the outcomes. This is a very nice paper where they show how we explain death and how we explain variation among institutions. So they show here that we can explain up to 70% of the deaths by physiology and comorbidity, but all the rest is explained by socioeconomic status of the hospital population, the hospital strain, hospital quality, and the treatments that we offer the patients. So it's not only us talking about this, we have really data showing that. How about survivorship? Now we are talking about post-COVID, and we hope that this is going to be a legacy because we have almost nothing on programs to enhance quality of life after survival. In low and middle income countries, we're still struggling to have patients surviving their hospital stay. But now we are getting epidemiological data on this. This is, for instance, one Brazilian study showing that, yes, after 1 year of being discharged, most of these patients have cognitive dysfunction. So what happens in high-income countries for sure happens in low resource settings. The problem that we do not have data on this burden, and certainly we do not have programs for the survivorship. Let's see what's going to be next now that the legacy of COVID is there. And last but not least, we need to improve our research capacity because there is certainly a lack of generalizability of data coming from high-income countries. We need our own questions and of course, our own answers. There are differences in the way that we're going to treat sepsis. Volume replacement, for instance, we now are starting to have data coming from this, very good data, actually. We have data and very good studies published coming from Africa, good studies coming from Brazil, from BRICnet, and from Latin America, the Andromeda shock that was used, for instance. All of these are, for instance, references in the last Surviving Sepsis campaign guidelines. So what we need most, I think that we still need to recognize the burden because we need this to convince people to improve sepsis care and sepsis survivorship. For this, as Caroline has mentioned, we need a better definition of sepsis, better prevention strategies. We need to prioritize the resource that we have, as we are not going to solve the resource and the infrastructure problem in the near future. We need to study better implementation strategies that are focused on our problems, on our own reality, and we need to improve our post-discharge care and our research capacity. Thank you very much.
You, Flavia, I think you met all our expectations and also made the point that even more is possible in terms of reducing harm and deaths in low and middle income countries. So we have now another 7 to 8 minutes for questions and comments. And I wonder, yes, please, if you may introduce yourself also, and please.
Yes, my name is Klaus Fleck. I'm a medical journalist for Medscape Germany. My question is, what are globally the most important pathogens, bacteria and viruses responsible for sepsis? And what about regional differences?
Jeanette, you want to answer or give your...
I don't have the full answer from the epidemiology. I'm not sure if Carolyn, do you have that from the studies that you guys conducted?
No, from our studies, we don't have that information as we are using administrative data. And in these data, pathogens are not really reliably coded. So that is nothing we can really answer.
But what is known and what has been expressed also in the WHO sepsis resolution, that most sepsis cases really come from community infections. For example, urinary tract and E. coli is a problem there. Pneumococci are, and there's vaccination against pneumococci, for example. For example, influenzas also, and I am saying this because it's not known And the vaccination rates, for example, is another issue for Germany, is only in the range of 30% against influenza and pneumococca, et cetera, and so there must be more data, and we lack data globally, but also on the country level, and just to be aware that the #1 cause of sepsis worldwide is respiratory tract infections. About 30% of them are viral, and the rest are other pathogens. A great deal is pneumococca, but not only. And this is different with nosocomial infections also. So it's complex. But just to get a notion, urinary tract infections are quite common causes. Abdominal infections are quite common sources. So that's all what we currently know. And policymakers and healthcare providers need to understand that almost any infection may end up in a sepsis and needs specific treatments.
The probability is higher for bacteria to cause sepsis than for viruses. Is that correct?
Yes, but still we are talking rightly a lot on AMR, antibiotic and antimicrobial resistance, but we must have also and develop new antibiotics, which is right, but we need also to stress more and this research and development of antivirals, and we must become also better to diagnose virals, and there are still gaps also in this field. So because it has been neglected too long, because industry has, because the margins for profits are much bigger for non-communicable diseases, which you take lifelong, et cetera, so a lot of issues that need to be addressed in the future also in this respect.
Thank you.
Other questions? Yes, please. Comments?
My name is Michael. I work at Charité as an internist and geriatrician. My question goes to Flavia. Thanks very much for your lovely presentation. I was wondering if at the community level, if you have any educational programs to educate people about sepsis. If not, how would you go about this yourself?
Yeah, I work with the Latin American Sepsis Institute here in Brazil, and we have a lot of data on our website for lay people regarding this. We have folders and we have small short videos explaining what sepsis is and what should be the warning signs. And now we are also launching a new project, which is quite nice. It's called Reabilita in Portuguese, which could sound in English like rehabilitation or something like that. And it's focused on survivorship. So we will have on our website healthcare professionals, it's a multi-professional website. For instance, we're going to have a speech therapist and a physiotherapist and a nurse teaching and training with videos and tests and tools, lay people how to deal with the survival of sepsis. So we do have this, and I think that social media and these small short videos and folders and this sort of things, they are very good tools to help lay people, and mostly focusing on the warning signs that they trying to teach them or train them how they need to seek for help when they have signs of infection. So I think it works. Our website is highly visited.
We have time for 1-2 more questions. So overall, yes, please.
I'm Silvanus. I'm a gynecologist from Nigeria. I work at the Rural Specialist Teaching Hospital. Just to ask, when we talk about hospital sepsis and we are looking for solutions to sepsis, let's not forget the pregnant women and puerperal sepsis. I think it's still a major cause of mortality in low-income countries. And I just thought we should hear a comment or two on that. Thank you.
Jeanette, you want, because WHO has done a lot on understanding maternal sepsis. And
so I think so I would echo that. I think it's very important. So the maternal child health program at WHO does focus on interventions to reduce maternal sepsis as well as neonatal sepsis. I think what we're trying to do here is remove the siloed approach in a sense, right? So we have to remember the populations, and sepsis can affect all people. And some people may be at higher risk from sepsis dependent on, what either they're going through a procedure, right? Or they're going through, labor, or they are a neonate, or they, for COVID, are older and have a chronic disease. So for each pathogen, there's and I want to address a little bit what the journalist was describing. It's like the patient and the pathogen, and there's that host interaction with the pathogen. And then depending on how that evolves, you may get sepsis, right? Or you may not. So I think we have to remember now what we're trying to say, like, not look at everything as a vertical program, like in malaria or tuberculosis or HIV, rather than that there are, infectious pathogens. The common causal pathway to death is through sepsis. Now, who gets sepsis from which pathogen will depend on the situation, in a sense, right? Who's the patient? What are they going through? And what is their body's host immune response? And then, of course, the service system that they're in, right? The resources that are available to care for that patient. So it's in that pathway which so I think 100% we have to be it's very important to acknowledge all the populations that may be develop sepsis.
I think this was crucial and summarizes in some way where the problems are. I can tell you that 6 years ago, even on the CDC was just focused on nosocomial infections, ignoring that 80 to 85% of people come with infections from outside. So the concept of sepsis needs to be understood. And also in WHO, there's a department and a group for neonatal sepsis, one for maternal sepsis. There's one on infection prevention. There is an assistant director general on AMR. Yeah, there's not somebody who is responsible really for the whole thing, for the crucial infection wouldn't be a problem if they would not be able to progress to sepsis. So that's the truth, and this is not understood, and we need to do anything, and that policymakers and also the people in the administrations and also at the RKI and the other, it's the EDC. We had with the EDC, the European CDC, ECDC, is by law or by regulations just committed to nosocomial infections. I learned this in a discussion that we had on World Sepsis Day. This is unbelievable. They say they cannot act and do something on community-acquired infections. So these limitations in the heads need to be overcome, and we have a lot of work to do. But I think this discussion and this summit, and what also with support of now from the Ministry of Health, also in Germany, we can make a difference, and I think it's worthwhile. So I take the privilege to thank all of you, especially the speakers, the discussants, and hopefully, we can continue, and also will have not only on the next World Health Summit, but also in other contexts, opportunities to spread this message and really make the requests and urges from the World Sepsis, WHO Sepsis Resolution happen, which says every member state needs to integrate sepsis in the national healthcare systems. This is what it's all about, and this needs to be understood. And thank you so much for your attention and the opportunity.